Hello, I'd like to welcome everybody to today's Research in Progress webinar presentation, which is integrating cross-sectoral health and social systems for the homeless. So I'd like to begin by introducing our speaker. For today, our presenter is Dr. Hee-Sung Jang. And Dr. Hee-Sung Jang is an Associate Professor of Public Administration in the Department of Public Administration at the University of North Texas. Her research explores nonprofit and government partnerships, local government management and policy choices, and the nonprofit sector in South Korea. Dr. Jang's research has been funded by the Johnson Center for Philanthropy and Nonprofit Leadership, the IBM Center for Business of Government, and the Aspen Institute. Also with us today, we have Dr. Jose Pagan. Dr. Pagan is Professor and Chair of the Department of Public Health Policy and Management at the College of Global Public Health in New York University. He also is Director of the Center for Health Innovation at the New York Academy of Medicine, an Adjunct Senior Fellow and member of the Executive Advisory Board of the Leonard Davis Institute of Health Economics at the University of Pennsylvania. Dr. Pagan received his PhD in economics from the University of New Mexico and is a former Robert Wood Johnson Foundation Health and Society Scholar with experience in health economics and population health. Over the years, his research has been funded through grants and contracts from the Department of Defense, the Agency for Healthcare Research and Quality, the National Institutes of Health, the Centers for Medicare and Medicaid Services, the European Commission, and the Robert Wood Johnson Foundation, among others. He is also a member of the Board of Directors of the Interdisciplinary Association for Population Health Science and a member of the National Advisory Committee of the Robert Wood Johnson Foundation's Health Policy Scholars. And he will be providing some commentary after our presentation. Without further ado, let me turn things over to Dr. Jang, who will do the presentation.
Okay.
Please continue, Dr. Jang. I think we might have resolved the audio issue, so please do continue speaking. Thank you.
Okay, so I guess some of you are hearing me as new, so let me just repeat a little bit about the service mechanism that we are presenting, which is a public policy designed homeless service unit that was originally created by McKinney-Vento of 1987, and it was really shaped and proposed to the localities in across the nation, and by emphasizing self-organization by local the local nonprofits, local entities, local stakeholders, and that which also emphasize more about the service performance and outcomes, and emphasize the engagement of non-governmental actors to be part of service unit, even allow them to be the leader of the service entities, and give quite a discretion for these localities to design their own service structures and governances. So that was quite a stark departure from more of top-down bureaucratic standards and formula-based and the uniform structure of previous service units. And we realized this continuum of care is novel and innovative, but this service, unit, is overly emphasizing the housing-related services by these housing-first approaches, and leaving these major and the health and human services to the responsibilities of local actors, like the local governments of the cities, counties, and nonprofit organizations. And the service actors realized huge cost that is not addressed by these public policies, and that is often left to the hands of hospitals and the clinics and the shelters. So so we wanted to understand how this continuum of care service unit that is designed by the federal policies are responding to the huge service hole of medical and health services for the homelessness. And by understanding how they are designing their service structure and understanding some of the challenges and barriers that experienced by the CoCs and hospitals and other members like the shelters and the clinics. And we realized this kind of service void was actually acknowledged by the public policy, like at the federal level, because the HUD issued emergency discharge coordination policy that is requiring local, like the Continuum of Care service units to identify how these hospitals and clinics are arranging and formally structuring discharge of homeless individuals in the prevention of recurring homelessness from when they are discharged from the hospitals and clinics. So our research aims are basically understand and assess this newly codified unit of homeless service mechanism of continuum care in our focus of improving health and equity among the homeless, and understand this collaborative governance structure in these very wicked issues of homelessness, and want to see how the non-state actors like nonprofit organizations are actually taking their roles in effective creation of collaborative governance and implementations of the services. And wanted to understand what is the impact of the management practices and the role of leadership in leading leading collaborative outcomes and outputs. And the last aim was newly added a research focus that in the process of research project that is understanding what is the dynamics among very distinctive and different stakeholders in participation of emergency discharge coordination processes. For this research, we are pulling different sources of data and creating somewhat massive data set that will be used better understanding of this like a CoC as a service unit and their impact to the the well-being and health of homeless population. And that this data set is used for us to generate some understanding, and also shared by a number of PhD students here in University of North Texas and University of Utah. And we conducted the two case studies, and that is a two-layered. One is case study of two communities and two CoCs, and that is for the county, the Salt Lake County and City and Dallas County and City. And we continued our case study to the two more communities and continuum of care by including Houston and Fort Worth for understanding of this stakeholder dynamics in a process of emergency discharge coordination. So if we can visualize the research process, we are our kind of major research discipline is public policy and public administration. So for generating more of this kind of theoretical like evidence of collaborative, like how the collaborative governance is exercised. At the same time, we wanted to offer practical advice and the directions for the practitioners who are designing and implementing and operating services for the homelessness. So our always the key focus is the policies, regulations, and the theories. But our understanding about policies and theories are always amplified by engaging deeply with the practitioners who are engaging these the policies and serving the client daily basis on site. So we even before this research, we had a publication with the 4 CoC cases with a deep the focus group understandings. Then this understanding lead us to 2 of case studies for this the research project with 2 counties and 3 counties. Then analyze the national HUD data and point-in-time measures and how the HUD funded CoCs and understand what is explaining some of kind of collaborative capacity and understanding what really matters for the successful kind of coordination of collaboration. And for this understanding, we conducted a national survey of self-organized, locally structured continuum of care networks of about 400 CoCs, and we had a 46% of response rate for this survey. I want to briefly mention for our research activities, and most of these proposed research activities for this grant was successfully completed, including the 2 case studies and a national survey. And we are very happy to continue our research endeavor in development of research grant to the RWJF and the IBM Center for the Government of Businesses, and the PI and co-PI myself is currently participating state-funded homeless service projects. For this presentation, I have 2 parts of findings that I want to share with you. And first part is about general understanding of this the service unit of Continuum of Care, and the findings are mostly from our national survey. And the second part of research is that deep understanding of the reality of the CoC addressing health and medical service demand of homelessness. And these findings are mostly coming from our case studies. So let me present our general findings about servicing of Continuum of Care. Continuum of Care as a service unit for the homelessness is locally initiated, structured, and designed, and they can have their own way of governance. They can choose their own way of governance. So we asked about the question how they govern their service units and their operation with many multiple members. And 36% of them answered they are governed by some type of steering committee that is represented by key stakeholders, like the stakeholders including shelters, hospital, clinic, and other like a court system, county and cities. But at the same time, like the more than 1 out of 4, like the 26% of them answered, they have one designated member organization that is taking a leading role, which is the lead organization governance shape. And for this demonstration, we want to show you like the Salt Lake County is choosing the shared governance as the way they govern their operations, and Dallas is having their own stand-alone nonprofit organization, 501c3, Metro Dallas Homeless Alliance as their governing body that is overarching entire 100 more like the member organizations. And most of them is like designating COC as a single homeless service entity that is serving their counties and cities. But like county has another service body that is some kind of somewhat in competition or coordination of the COC for some of the service dimensions. And 39 was the average number of service, like the member agencies as part of the Continuum of Care, and most of them say they are kind of getting the funding support other than HUD. And the Salt Lake County was saying they are only relying on the funding from the HUD. We, as part of this research project, we developed a massive, like a very kind of large database for for understanding unique characteristics of communities in terms of their homelessness. And we are seeing, like if you are seeing the second law of this table, there's some disparity in terms of per capita homelessness in each of the area. Like the Salt Lake City and County is a lot more than other areas, and the funding is also distributed in a somewhat kind of very unique ways. So the per homeless funding also vary. And the point-in-time measure of the homelessness also offering their kind of medical conditions of their homeless population. So we found 1 out of 5 homeless population in nation is suffered from like a severe mental disease, and there is like a 16% of the homeless is kind of the patient of like the chronic substance abuse and so on. So if you are seeing this kind of percentage distribution of 4 areas that we examined, like the Salt Lake COC is showing like the highest in terms of severely mentally ill population, and most other kind of measures are kind of showing there is obviously quite a high demand of medical service response to the homeless population there in Salt Lake County. From our focus group kind of interview and studies, we realized there are set of medical services that are very much demanded, and we asked this question to the CoCs whether they are providing this more homeless kind of focused medical services in their CoC operations. So it was very interesting that more than 80% of CoCs are offering mental health and this kind of substance use counseling services. And second category of services are services that is directly that is more to the homeless, the people on site where they are, and 42% of CoCs are offering services like the medical and health services in shelter, and they are offering services by kind of providing mobile clinic to the where the homeless population is focused. And about 30 to kind of 25% of CoCs are offering substance abuse related services, and less than 20% of CoCs are offering kind of more primary care or the nursing beds in shelter. And we realized this nursing beds in shelter was most needed, services that can kind of prevent exacerbation of health and medical condition of homelessness, but it was not quite much provided by many of the CoCs or homeless service providers. So this is the kind of some results from our national survey. So what is the impact of this newly kind of designed or shaped CoCs in their contribution to the medical care and medical service coordinations? So less than half of them answered they see increased involvement of healthcare providers in the conversation of creating and developing more effective medical service response to the homelessness. And they, 42% of them answered they are experiencing increased member commitment, in addressing homeless care, the healthcare needs of homelessness. And 34% answered they are experiencing more different type of services are offered. And we also asked what is their kind of major challenges in CoC collaboration in general. And 92%, it was very dominant answer by the CoCs answered, they said, the resource is the issue to address the service demand and the urgent kind of response to the needs of the homelessness. And 82% of them answered these federal mandates are coming to them as a requirement in a competition to earn more of the HUD funding, but these mandates are not properly resourced by the federal administration. So they answered these unfunded federal policy mandates are the biggest kind of challenge they experience. And since the network is composed by members that are from their communities, and none of these members are required to be part of this service network, they express this network sustainability is always the issue, and they have to exercise their management or administrative kind of actions to create very committed and sustainable service networks. And these kind of administrative efforts were not quite well funded by the like kind of overt processes. And we found like about 80% of them answered this support from the local elected official will be the issue if they don't have one. And power dynamics among the members could be the kind of the challenge, right? And accountability and engagement of the stakeholder was found top of these challenges they are experiencing. And I want to move to the part two presentation about understanding. This part is understanding reality of service collaboration and coordination for medical and health services. And these the findings are mostly generated from the first case studies and analysis of national databases. From our interview and the case, and the focus group studies with two service community of Salt Lake and Dallas, we realized one of the key for success of collaborative governance for the homelessness is the leadership, especially leadership for the cause. So if they are having a person who is well-known, well-established, and highly reputable, and have such a strong and solid community assets, and they can kind of overcome many of the challenges. And they mentioned also the political support by the mayors was the key for them move forward and generate visibility and generate support from the community. And the representation from different service industries, including medical, the nonprofits and the hospitals and the shelters, was the key for initial success or the planning and designing and solidifying their collaboration and coordination processes. For the medical services, it was quite obvious, it was uniformly kind of mentioned by our cases that the information and information sharing and the communication was the big issue for addressing medical service demand of homelessness. It's because the information about the patients are not required to be shared by the law, and there is kind of communication issue for the different service providers, like hospitals and clinics and shelters, because they don't use the same software. They are on their own software, and there is no kind of requirement for them to share or the structure for them to share this information about the patient. So the communication was quite fragmented, and information was not well shared among different service industries or different service units. And they mentioned this. There is quite a demand of primary care service capacity and shelter and the respite beds, like the nursing bed that is in the shelter spaces, but there was not much agreement was made amongst the service providers or the stakeholders who would pay for what and who will be in charge of providing resources or who will be responsible of operating these service units. So the services were very fragmented as well. Okay, here is just a draft presentation of what frequency that we analyzed for understanding medical services for the homelessness. In those cases, it was very obvious that they mentioned much about the challenges of high utilizers of like the ER services. So emergency room is like from our visitation of Parkland Hospital there in Taos County. We were seeing this, like the waiting room was full of people, like, and the social worker who was kind of administering people's admission was saying many of them are homeless. They don't have any designated addresses to be discharged. And some of them are utilizing their ER as a kind of night shelter or like a day shelter when it is too hot or it is rainy outside. So this county hospital is covering much of the expenses related with high utilizing kind of homeless populations. And they're in a sort like area. They are still in the process of identifying what is the role of the shelter and what is the role of the county. Okay. So medical service. So we don't have much time, but let me briefly present what is the challenge that was experienced for the matter of medical service collaboration. So the discharge process was required by the law, but still is very informal as a matter of the fact and very ad hoc basis because it's hard to develop any commitment among service providers. And they are relying heavily on major major hospitals and some of these private hospitals. So here is, again, they are mentioning about like the emergency discharge as the major like the challenges, and they are talking about the lack of directions and the lack of understanding and lack of data sharing process that has been built. And here is one of research that we conducted to understand the factors affecting success of HUD funding, and we understand this nonprofit leadership and nonprofit engagement was the factor, but it's a negative way. So when nonprofit is a leading agency of the COC, they are less likely successful of getting kind of bigger size of the HUD funding for their services, which was very surprising and kind of give us some question mark to understand better of the internal dynamics of why this nonprofit leadership is kind of negatively affecting their funding success. And we found this solid collaboration and partnership and network engagement that is measured by the participation rate and the sustainability of the network by measured the age was positively associated with HUD funding success. So far, we realized we learned from this the research project that this new the new design of service system for the homelessness is devolving responsibility from the federal the agency to the local entities. So these COCs are heavily responsible for housing-related services, but they are also a focal point of developing medical and health services for the homelessness as well. And we found some of institutional barriers for this community continuum of the care community collaboration, and one of them was definitely unfunded federal mandate that is requiring the CoCs to arrange some of service responses without proper federal support, and their overall network capacity was mentioned. And we found this data sharing among these different service providers and service industry was the key of the challenge they are experiencing and try to address. So this is our kind of next step of the research that want to understand how the this information management system is kind of easy of these challenges and assist this homeless service unit more aligned and overcome this fragmentation. And briefly, I want to briefly mention then how we disseminate this research in different ways. So we conducted community forums with stakeholders participated, and we learned from them, and they learned from our findings. And we generate 3 dissertations from this research, and we engage in, from these findings, we could engage in like a state-funded project there in state of Utah and state of Texas. And here's some pictures that is capturing the moment of the community forum there in Salt Lake City and here in Texas. Thank you very much.
Thank you, Dr. Zhang. And before we turn things over to Dr. Pagan for his comments, I do want to just thank everyone again for your patience at the top of the hour as we work through some technical difficulties. If you'll check your chat box, you will see the bios for both of our speakers have been placed there, along with a link for more information. We are running a little tight on time, but if you do have questions, please go ahead and enter those in the chat box. And after Dr. Pagan's commentary, we will get to any if they are there, or get to as many as we can. And with that, I'm going to hand things over to Jose. Thank you.
Thank you, Anna. Thank you, Dr. Yan. That was a very, very interesting project. You might hear a little bit of background there now, but so ignore it. I'll be brief. It's a jackhammer outside. Anyway, I thought that your project of integrating health and social systems basically to address homelessness, it's a very high impact project, very ambitious, very impressive how you were able to conduct all the work and sort of like do a comparison analysis between the the Dallas-Fort Worth area and the Salt Lake City. The structure of these programs, it's what makes it interesting, right? Because there's a lot of freedom as to what local organizations can do, and it allows you to think more carefully as to which model is working, which one it isn't, and you have a lot of data now to basically sit down and to think about how to what's working and what isn't working. You're looking. I spent a lot of time thinking about this issue of what is the optimal coalition that you can put together to solve a problem in health and healthcare, especially problems that have to deal with social aspects that impact healthcare. I tend to think about that to create collaborative entities, to address problems like this. We need to pay attention to 3 things at a local level. One is history, understand how communities came together, sort of like what are the players, what is the history of these players working together, to sort of like understand what you're getting into when it comes to getting them to work together. I've seen that in cities like Dallas-Fort Worth, for example, where they share data across hospitals easily, but you won't see the same in other cities in Texas, for example. The other one is like understanding the resources that are available at the local level. Who are the players who have the money, basically, and then the other key component which came up is this whole issue of local leadership. Who's gonna carry the flag and say this is important to our community? And I think without any of those having those three ingredients can make a huge difference. So you need, one of the things that I noticed is like for many of this, you need a few leaders, you need strong organizations, you need a place to meet, a neutral convener, someone that is going to provide structure to these coalitions and partnerships to be successful. It's almost like one of the things that somebody told me when I was managing this very large project was schedule a meeting every Wednesday at 8 a.m. for your project, and things will work. So it's almost like leaving the space for these discussions to happen. One thing that I noticed is that you didn't talk about the payers, whether payers were at the table in these two communities, and I'm curious as to whether there are any of them interested in this, or for example, Medicaid managed care plans, or so it's something to think about. I know in New York City, for example, that's an important component when it comes to the provision of homeless services. And I have a couple other observations. One is this whole issue of collaborative governance. The findings from your survey were very interesting. You mentioned that a third of the CoCs use a shared governance model, whereas 25% have one designated organization, like in Dallas, compared to Salt Lake City. It was interesting to me that Dallas had also many member agencies. So, my first thought on that was that if you need to manage more than 100 agencies to work together, you do have to have somebody designated to make it work. Whereas when you have a complex problems, at the same time you only have 26 members, a shared governance model may be more feasible. And that came out of your results when you look at Salt Lake. The other thing that I found interesting is how different the problems were in the two communities that you compare. One, Salt Lake City had a lot more complex medical service needs, mental illness, substance abuse, domestic violence. And I don't know if that's driven the structure that they picked, the shared governance model that evolved there is connected to maybe the complexity of the problems that they have. But anyway, that was a very interesting result. And then at the end, I'll just say on the case studies, what you mentioned, the support. People told you about the support from the mayor of Dallas. How I think for many problems like this, where you need to integrate or bring people together, you need such a champion. And that's what I've seen happens in cities. When you have a champion, then agencies that typically focus on have different goals will come together to solve a problem. And I've seen this in Philadelphia, I've seen it in LA, in studies that we have done, and it's sort of consistent with what you found there. So my last comment would be on this idea of the homeless management information system. I think that's a great idea. I think it's much needed. My only comment would be to when we're thinking about that it's the easy part. I think is the data integration piece. Meaning it's not easy anyway. It's still hard. But one thing is sharing the data. Another one is thinking about like how people will use that data. And we tend to everything that I've seen with data integration like that, we tend to forget that second piece. How do we create a system where people have the technical capacity to share data in ways that are useful? So the data is shared, but then the way the data is presented to the different partners is sort of like the more difficult part of it. So thank you so much for that was It sounded like a great project, and you got a lot out of it, and I think we got a lot out of it. So that's it. Those are my comments. Thanks.
Thank you very much.
Thanks, Jose.
Those are amazing.
Dr. Zhang, would you like to address the question about payors and whether payors were involved in the cases you looked at?
Yes. Well, many of these interviewee mentioned about, like, state of Texas, is the state that is not expanding this Medicaid, and there the CoCs under this state 18 states are not clear of how they can pay for the services, and the county hospital there in Dallas was mentioning they have to figure out how to pay because there is no clear sources of resources to cover the medical service expenses. And out of just keeping these the patient in their ER a day, it's approximately the $1,200 per day or more. So they have to cover it up out of their kind of county, like a state funding, and it wasn't clear of any of these interviewee of understanding who's paying for what portion of services. So we would like to, that would be great next project, that to understand what is the the funding structure or the paying structure for these medical services, especially those a state that is non-Medicaid expanded a state, and that will be very interesting, and it's because the homeless population is the most vulnerable population that is not much of access to the healthcare system. So, and that is related to the resources.
Absolutely, and I'm struck. I was struck during your presentation by the consistency with which capacity constraints and lack of resources kept turning up in both your quantitative and your qualitative findings across sites in your survey. So I think that, and I think that's going to be true of most research conducted that has a public sector component. I think you're going to get large numbers of people saying we need more. So I think having those voices at the table and understanding a little better how the existing resources could be better leveraged or leveraged more efficiently and effectively would really help add to the recommendation list to come out of this research. So I really want to thank you
absolutely.
Again. I especially want to thank Dr. Zhang and Dr. Pagan for sticking with us through our technical difficulties. I want to thank those of you on the line for doing so as well. We will get this posted, and hopefully the audio will come through. As you can see on your screen, if you're joining us online, we do have a couple of upcoming webinars ahead. We hope that you will join us for those, and hopefully we will be able to resolve any issues with our service provider before then. And thank you again for your patience. We want to obviously acknowledge the Robert Wood Johnson Foundation for its support. Thank you all for joining us, and we look forward to talking with you soon. Bye-bye.
Thank you.
Thank you.